I'm in the Chicagoland area, so we had a little bit of snow not too long ago, but it's pretty boring where I'm at. And there's a picture of a map of the U.S. as the background, and all those little lights that are on. I'm thinking of those like the COVID hotspots, and we're probably one of those. But certainly excited to have you here. I know it's difficult with distance-based everything right now. I certainly appreciate you spending some time with me. I'm excited to be here, excited to give a little webinar talking about what it's like to be an APRN in the OR, which is, it's a unique scenario that some of you may be in the position to either do or have already done. But that said, the biggest thing about this is, there's things that maybe I didn't know going into it that would be nice to have been taught. And my goal is to try to give you some of those pointers so maybe you can make that transition a little smoother than it was for me. And certainly those that have already gone through this will go, oh my gosh, that's me, or that's not me. And, we can learn from each other. So anyway, I'm super glad you're here. I'm a DNP. I have, 5 years now that I've been a DNP, and I do a fair amount in education now. I work for NIFA as the program director for their college division, trying to help kind of expand some of their offerings and help people have good access to training. A lot of people go through the program and basically want to go on for more and expand their skill sets and help the people that they were around go further too. So we work with a lot of different people to try to expand awareness of this program that I think quite honestly made a huge difference in my career and a lot of yours too, I'm sure, if you've gone through it. I own a company called Skills on Point, and Skills on Point is a medical education company that we do CE we work very complementarily with NIFA, and we have a different product, but we work to help with all the privileging and procedural skills that go alongside with being in the hospital and getting credentialed. And on top of that, I'm the founder and president of something called Mission Skills, which is a 501c3 where we basically help people get training for free if they want to go do medical missions. And some of that's more local, some of that's international, but super fun to be able to give back and help people out. Because, when you have a training company and all the supplies and everything, why not help people out when they want to do something good with their skill set? So it's kind of where I'm at with things. So anyway, our night's going to be a couple simple topics. We're going to talk about the intro to the OR as an APRN, what that looks like, how your skill level affects your employment, how billing works for procedures, the RNFA versus the APRN RNFA billing, how that's a little bit different, negotiating your RNFA training based on billing plans, and how you'll be able to hopefully expand your skill sets and then also expand your billables and then your salary commensurate to the effort you're putting into it. There's a lot of work and time that many of you have gone through to become APRNs, and certainly that's a pretty big undertaking, and that's years of time, suffering, struggling, the expense of it, the family time that you had to put in the back burner, and it's a big deal. So you should be compensated for that appropriately. So we'll talk about some of the things that I didn't know that maybe will be beneficial for you too. And then some Q&A time. So about me, what's my deal? Well, I was in the Air Force for 6 years and got out in 2007. In that time, I became a paramedic and then became an RN and worked in an ICU in 2008. And basically from then on, just basically worked for a couple of years, went back to school, got a BSN, and then went straight through an FNP and then went to CV surgery. So my point of putting that there is not to say my resume, but really it's up to the point of getting into surgery. I'd never been in surgery. I had no idea anything about the OR other than that it's this cool place that, it seems like everything's sterile and it's like MASH and it's awesome. And, I have no idea anything about it. So the point is, as a family nurse practitioner, it was a pretty big transition having never been in an OR. And as a family nurse practitioner, just that skill set is very specific to be outpatient based. So even being inpatient was a little bit difficult. And on top of that, being in the operating room was just a lot of changes all at once. So I know some of you have all been through that if you've been an FNP in the hospital, and it's just a lot of nuances. Nothing impossible, it's just nuances. So I went through NIFA as the APRN in 2015, a year after I was already in my role. And the reason that that's pretty common to do for most people is when you go through actually getting hired into a role, sometimes the expense of going through a program like this, if it's going to be compensated through the employer, many times you'll have to give a capital expense request and then they'll pay for it on the next capital cycle, which is what happened to me. They said, sure, we want you to do this. If you're going to be in CV surgery, you need to know these skills. But obviously we got to earmark some money for this. So that's what happened. So I spent the first year of my NP career kind of learning all the ropes from an NP that wasn't procedural. And basically that was all like the rounding and consults and all of that stuff, discharge summaries, office stuff, and then procedures and all that fun stuff. And then a year later, again in 15, started in the OR. Did my DNP and then started Skills on Point again for procedural content that I had a hard time finding. So it was something that I wanted to make it easier for those that followed me. And then after that, in 2019, we did some nonprofit stuff and are continuing to grow that, which is really super fun. Working on some grants right now. I became a program director for NIFA in 2019, and also just finished my adult geriatric acute care in 2020 from UPenn because I went back to be acute care in the whole consensus model has been pushing a little bit where I work in the Chicagoland area to have an acute care for being in the hospital. So went back, I was like, okay, I'm done. FNP, DNP, done forever. Just kidding, back for more. But now I'm officially done. There's nothing else for me to do. And I say that because I'm sure something else will show up because there's always something else. But anyway, I'm a lifelong learner, so you can say. So after going through all the training and all this education, you get into the OR. And basically you realize this is a brave new world. You're so excited. Oh my gosh, you could get a picture and you can see all the things behind there. Sterile room, you know, the cool epoxy floor and the lights and the cameras. And, you know, you're just basically like freaking out with excitement the first time you're in there, not knowing what to do. And everyone else is basically like, oh my gosh, everyone knows what they're doing except you. And here you are, like, I don't know what to do with my hands, freaking out and worried about if you're going to touch something. And all the surgical techs are like, just judging you, waiting for you to make mistakes. And you know that at some point in time, you're going to break sterility and freak out. And they're going to say, don't touch that. And, you know, they got to undo something you did wrong. And it happens all the time. This is part of the process. It's part of learning. And I will say the biggest thing is, you know, that's all part of the educational process, especially if you're an NP, because you've never been in the OR. If you've been an RNFA already, an OR nurse, like a CNOR, circulating and then scrubbing, you know where the supplies are, you know where the gear is, you know what that equipment does, you know, all that stuff. But, you know, then here we are, you know, RNs that go straight into an NP program, having never been in the OR. And then, you know, here we are, you're in the operating room and you're just excited by the bells and whistles, and you seem like a liability, honestly. Although you're not a liability necessarily, there are some people that kind of don't realize that they could be a liability. And that's where we get kind of this bad stigma of APRNs in the OR, where you're untrained or not as good as or whatever. So that's a big trend push away from that as we're getting more and more high quality training programs like NIFA to get people ready for that initial transition from pre to in the OR. I can tell you the 6-day course that I did at the time, now it's a 5-day course. That was probably the biggest thing for me, just the eye opener, to give me some of those baseline skills, just how to scrub and how to gown and how to, you know, just the basic things that you just don't think about. You know, it's like, okay, I'm sure it happens, but how do I do that? Or, I don't know, how to close versus open gloving. It's all taught, so you know what you're doing with that. So that gave me the confidence to walk in there and at least be able to fake it till I could make it. And the other thing with this too is you got to realize that everyone else is looking for that same seat at the table, and you very well may be fresh meat to all the surge techs that are looking at you going like, oh, here we go, here's another one. Or you may be fighting for a seat that is a very coveted position to be the first assistant. And that really varies on your hospital environment, as I'm sure you've found that in a big teaching hospital, there's many layers of education. There's the interns and the residents and the different types of students and, you know, fellows and attendings and co-attendings. And there's all kinds of stuff where you're going to be in line to get at your first assisting seat, so to speak. But that said, if you're in a rural facility or in an outpatient ambulatory surgical center or something like that, you may be the very only person that's going to work in that role. So you're there all day long, every day, and it's no big deal. So just realize that it's a big deal to be in that first assist role. And if you take that lightly, people are going to be not so happy with you because they would love to have your seat. It is what it is. So the question is, why are you here in the OR instead of a surge tech first assist or an RNFA or a PA? And really what it boils down to is every situation is unique, but you have to realize that sometimes it's billing, sometimes it's flexibility, sometimes it's just the hospital system. But there are reasons you have to think about, like, why am I here? What's the benefit of me being here versus someone else? And typically when it boils down to it, it's going to be your payer mix for your insurance, and also the continuity you can provide as an RNFA, and know about the case, going out to the floor and rounding on the patients and having daily continuity. I think that's a really big benefit that I have over the RNFA, who's phenomenal RNFA that I work with. But her and I both assist. She does cases and basically lives in the OR, right? That's her thing. And my role is more continuity based. So I would see them in pre-op, I would see them in the hospital. If they're there before surgery, I would round on them, put their pre-op orders in, go to the OR, assist, and then manage them post-operatively until they go home, and then see them in the clinic. So I can speak to it at a different layer than she can. But that said, she's probably better in the OR than I am because she's there all the time, right? So the question is, what's more important and what's the continuity they're looking for. So every location will have a different dynamic with that. But just realize that there is some background questions to even get to the point of having an APRN in the ORs. It's newer in a lot of places, and it's a great thing. It's just that in a lot of places, PAs traditionally are in the OR and NPs are traditionally not. And that is changing. Are there drawbacks to this? Really it boils down to what your role is. I know people that do ambulatory surgical center roles, and they are there, they get there at the same time every day. They leave at the same time every day. There's no after hours. There's no weekends and holidays. It's pretty cut and dry. And certainly the opposite of that is when you're on like a trauma call or a surgical call for like CV. You never know what you're going to be doing. You could be in there in the middle of the night with a AAA or a dissection, or who knows. It just is what it is. So you have to decide what's the drawback for this, and is this something you're willing to sacrifice? Sometimes the financial motivator of going to the OR and getting more money out of that seems pretty cool, but at the same time, that may cost you some family time, and depending on where you're at in life, that may be a bigger motivator. Are the benefits? Yeah, absolutely. If you have an opportunity to get in the OR, I can tell you, even if it sucks for a while with your schedule, it's worth it, period. To get the training, to be able to put that on your CV or resume and say, I can go to the OR, I am a certified registered nurse first assistant, or I've at least gone through a program and not necessarily gone through the certification, although I'd recommend you do that. If you're an APRN, just having that to travel with you opens up a lot of doors. And I would highly, highly, highly encourage, if someone's willing to train you and you have that opportunity, take it, because it doesn't always come around twice. So that's really the biggest thing, is it will open up doors. You will have different offers out there. You can always go PRN. You could always, do some locums work. You can make some great money doing this. But that said, you just don't see that quite the same in clinic medicine. The hierarchy, as you probably have learned, is clinic medicine is kind of on the lower payment. You get another 10 to 15,000 on average annual salary when you get inpatient, and then maybe another 10 to 15,000 on top of that when you're in the operating room, plus sometimes more if you're on call and there's more weekends and call and pay. And you can do pretty well for yourself with that skill set. And then it never goes away. Once you have that training, it's something you can put on there. It's yours to keep. So with that said, how does your skill level affect your employment? I think that's an important question, and it's a question that I didn't really particularly think about until I was getting through my FNP program, realizing that as an FNP working in CV surgery, I was going to have some gaps. And this is just, the biggest question here is getting hired in 2020 to 2021. What does that really look like? We had COVID, we had all this stuff going on where hospitals were kind of cutting back on the OR cases because they wanted to have more ventilators available, which is totally appropriate. And then we saw that there's now kind of coming back this push, at least where I'm at, we're seeing a pretty good push right now back to being busier, and the volumes are holding up despite more upticking trends in COVID numbers. Intermittently, they kind of go up, they go down, they go up, they go down. We've had more ventilators available, so at least the OR is clicking forward. But that said, the question is, in that environment, how do you stand out, especially as a new grad? What is it that you can do to make yourself more appealing to an employer, whether it's a hospital system or an independent practice that's going to have surgical part of this? It really boils down to what your training is from, what kind of organization or university, and really how well you're prepared in that particular program. And I say that because with Skills on Point, I go to a lot of different universities, and we train a lot of places on site, and we also offer content online and distance-based because of COVID. And I can tell you that there is a big difference between universities. And they're not necessarily the ones you'd expect to be the good ones versus the bad ones. It's just everyone's reacting in a unique way to what's going on with COVID, and some are really designed for that online environment, some are not. And really, when you talk about skills training, privileges and procedures and operating room kind of stuff, the reality is that's just not something that you're going to find consistently across the gamut. And NOMF criteria is a big thing that they're looking for. So NONPF is this big overarching organization looking at all the different things that are the national criteria for nurse practitioner faculty and their programming. So if you don't really have all those benchmarks met for your program, it's going to be a problem. And really, skills training is one of the big things where if you don't get that in your program, a lot of people will go and seek out standalone programs like Skills on Point or some other competitors out there across the country. They're all doing basically the same thing. We're providing access to the skills that you need to do the job. And that may be like suturing or office procedures or chest tubes, central lines, or whatever, those kind of things that you have to get the box checked off to proceed. And for some people, that's really difficult because where you live may be really far from those programs. So all to say, the program itself is a big part of that, but how do you really stand out from that is if you want to be in the OR, I would say the best thing you can do is get an RNFA. And to that, I asked this question, which NP program certification or specialty covers operative medicine? And the answer is none of them. Okay, so whether an FNP or an adult general acute care, it does not matter. None of them actually give you any kind of certification in the operating room because as a standalone certification, that's not part of the scope of practice. And if you want to get a hospital credential or I should say a privilege in that specific area to be assisting in the OR or to open and close or do all the different things that every hospital has their unique privileging form to request, you have to have specialized training above and beyond your certification. And what that sometimes looks like at hospitals will be the physician will provide you with dedicated one-on-one training. And that's kind of more happenstance. It's not as regimented, and it's certainly not standardized or accredited. And there may be some people that have fantastic preceptors and teachers that are willing to do that for you, but not everybody does. And that's where programs like NIFA come in, where they can provide you a validated, standardized, credentialed process to make sure that you have met those benchmarks. For some people, those are things you already knew as being an RN in the OR. For some people like me, that was like starting from scratch. And it's a big deal, right? You don't know the things you don't know, and you are basically walking in going, holy smokes, this is a brand new world and I don't know what I'm doing here. So it was very valuable for me. And I can say I wouldn't have had the job unless I had that training. But the benefit of that was I was able to negotiate that into my job. And not everybody's able to do that, but that's just kind of part of the process. So the other question is, what else do you need to know for your position to really stand out? And again, the best thing I would say, my advice is if you already work in the healthcare system, which is a pretty consistent theme, if you already want to work somewhere, talk to the person that is kind of like your dream job, current person. You say, oh, you got the job I wish. Talk to them. What is it that you have on the credentialing that I don't have? And quite honestly, you don't have to ask them half the time. You can just go to the hospital's intranet and go sneak up on their privileges. And those are usually, universally available. You can pull those up and you can see what are the things that they are able to do when they're providing care, whether it's art lines, chest tubes, central lines, putting in external ventricular drains or whatever. It doesn't matter what it is. If that job requires that set of credentials, those are the things that you need to put on paper. And obviously, if you're going to be in the OR, first assisting is hands down one of the things you need to do. Otherwise, you're not going to be in that first pile of people that go on to the next level of interviews. And I will tell you right now, there are plenty of people that are going through multiple interviews for one position just because there are so many applicants. There's so many schools out there pumping out NPs, and you have to stand out somehow. Otherwise, you're just kind of throwing yourself out there. You can be the best possible applicant, but if they don't know about you, they don't know about you. You're in that one zone of, how do you get your name out there? And quite honestly, skills training is the difference. That's what really gets you out there. And being an RNFA, walking in the door, that's hands down going to get you the job. What positions are most sought after and why? This is a question I get asked all the time, so I put this on here. The reality is, when it comes to being in the OR, you'll find that there are probably 3 or 4 that are the most financially beneficial, and they do come with some time expectations. So do realize that call is pretty common with these, but not all of them. Plastic surgery does really well because there's a lot of cash pay. If you are like CV surgery, ortho, those tend to do pretty well. General surgery does okay. That said, the repayment's not always great on some of their cases. So Probably the biggest gold mine out there is spine. Honestly, you just the repayment for RNFAs is phenomenal for that. Spine neurosurgery, it's just really, really high. So you can justify a really high position in those, and you'll see some pretty good postings. Do you realize that there is some of the billing that goes into that we'll talk about that's very particular as to how you bill? It depends if you're hospital owned, if you're going to see all of the benefit possible for your billing in the OR as a first assistant compared to if you are like a separate entity working in a healthcare organization. You'll see a lot more benefit financially if you are not owned also by the hospital. And I'll give myself as an example of that. I work in CV surgery, and if I'm doing a surgery like a bypass plus vein harvesting, if I do the vein harvesting, you go, well, vein harvesting plus assisting a CV case, awesome. From a freelance, I could probably pull in a couple grand for that. If I'm doing that for the hospital organization, it's going to net them $7. And it's like, what? You're giving me $7 for that? But their insurance bundle that they've created doesn't really have a whole lot of room for extraneous stuff in there. It is pretty cut and dry. Unless there's complications, there's really no room for expanding on that. And that is a hospital to hospital thing to realize. You can say, I'm going to make you all this money. I can do all this. But when it comes down to it, they go, well, you're not really going to make us that much more money because we didn't do a very good job negotiating. So it's not always up to you. Now, the one time you may see a lot more money, as I mentioned, is if you are freelance, if you're doing this on your own. And not to say that everybody does this out the gate, but there are plenty of people that do very, very well as APRN first assists who are independent and basically just work as a freelance RNFA, go and doing cases, they bill for themselves, and they're basically their own company. You can do a lot more in revenue because you're billing outside of the hospital. You're basically coming in as like an outside consultant, so to speak. So you can just bill separate from the case, and you can actually get the full repayment that way. So that's how people tend to do probably the most revenue. But that said, it's not as consistent. You're not necessarily an employee. You may be, depending on the organization, if they have like a contract with like a locums company or like a first assist training company or first assist staffing company rather. But that said, it's not always a guarantee. So you may have your own insurance and malpractice and some more expenses. So there's no perfect way of doing it, depending on what you like your lifestyle to be. That's really what it boils down to. How stable do you want it to be is the question. Okay, so real quickly, how billing works for procedures. It seems kind of cut and dry, and I've already kind of alluded to some of it, but I want to bring this up because I didn't know this at all when I was starting out. And I thought this was pretty valuable to learn and to kind of throw it out there. So indulge me if you will. So a patient has a complaint. Let's say they're having chest pain, right? They go to see their doctor and they say, doctor, I'm having this chest pain. I don't feel so great. What am I supposed to do about this? And the doctor says, how long have you had this chest pain? Work them up. And then, you go through the whole rigmarole, you get the review of systems and the exam, and then here we are. And then they're going to get billed as established evaluation management code for an outpatient visit. So this is kind of what we talk about, the old style of medicine where you have this pay per play where you go in there, you get seen, it's basically fee for services, you're done. So you pay a couple $100, you see your primary care team, and then, they're having chest pain. So let's do a stress test, or let's go do some enzymes or do an EKG or whatever. And then we're going to send you over to cardiology. Okay, so you get this referral to cardiology. Cardiology sees the patient and says, hey, it's nice to meet you. I'm a cardiologist. I hear you have some heart problems, blah, blah, blah. Let's do a cath. So they do this new consult charge for the visit. They schedule surgery or procedure or whatever. And, that whole process, again, you have a new consult, new charge, all this stuff. This is basically a la carte billing at its finest. This is, again, what's been around for a very long time. So you get a cath, you get whatever, and then let's say, oh no, you've got 3 vessel disease with some left main, we're going for a bypass. Again, this process can kind of circulate back and forth over and over again. You got another referral in there, you go to CV surgery. I walk in the room and go, sorry, no stents for you, you're getting surgery. And they go, oh man, is what it is. And here we are. Now we're going to go through insurance approval. And then basically you'll see imaging or other, echoes and carotid scans and all kinds of fun stuff, pulmonary function tests, all this stuff to risk stratify the patient. So all these things are happening. Okay, this may take a couple of weeks. If it's an outpatient, it happens pretty quick if you're an inpatient. But that said, these can take a while to get all this stuff together, and realize that up to this point, everything is a la carte billing. So as a nurse practitioner working in this role, you can do pretty well. You can bill for all this stuff. You could bill as a PCP. You could bill as the specialist in cardiology. You could bill as the CV surgery nurse practitioner doing the consult, ordering tests, doing all this stuff. So, you're adding value to the actual, the case, so to speak. And then we finally get this procedure that is scheduled, it occurs, and then, basically it's approved, scheduled, occurs, and then we live in this little thing called the surgical bundle. And if you've never heard of this surgical bundle, the other thing is called a DRG, diagnosis related group. And what that really means is it's basically a lump of cash that the hospital gets based off of the CPT code, which is a procedural code. And basically that's what, let's say it's 100 grand, 200 grand, whatever it is for like a big surgery. That's what they are able to bill for. And that's it. So whatever you add after that, it just kind of falls on deaf ears. You have to see the patient every day. You assist in the surgery, you assist every day in the hospital before they go home. And then, basically for 90 days after they're in the hospital, you're kind of in that bundle, and you may be still dealing with 3 or 4 post-op visits, but you're not going to get paid for any of those. And just do realize that this is a kind of a big deal to know when you're negotiating in this brand new role. It goes, oh my gosh, it's so shiny. I love that position. CV surgery. Oh, general surgery, obstetrics, going to do surgery. It sounds really cool, but do realize that there is a backside of this where you're basically going to be working for free from surgery onward. And when you see people preoperatively, all of a sudden they're like, well, you're in the interview and they're like, well, interviewing the surgeon, well, I see all the pre-ops, but you'll see all the people after surgery or in their post-ops. You go, oh, okay, sounds fair, whatever, makes sense. Well, what they're really telling you is you're not going to be able to bill for anything. And if you happen to be in an RVU, or relative value unit, it's basically a work RVU, is assigning a number based on how much value there is to how much effort you're putting in. It's not a receivable. It's just basically what you're able to bill for. It doesn't mean it actually comes in to your wallet, because it's not really fair to say, well, your payer mix is kind of low, so you're not going to get as much money. The RVU model is basically saying there's a shared risk there, and this is how much work you put in. So if you see more patients, we'll give you more money. And the problem with that with surgical roles is that it's a common trend that's coming about in the last probably 5 or 6 years to see NPs going into a surgical role being offered an RVU position. I can't tell you how much I recommend against that. And the reason for that is, just like I mentioned, the surgeon's going to want to bill for what they're billing for, because they're the surgeon. Of course, they want to get the highest billing possible for procedures. You can only bill 80%. If you're in the clinic, it's 85%. And for them, it's 100% for everything. So why would they possibly want to let you bill at a lesser amount? Because the overall volume coming in is higher. The problem is you can't bill and see those receivables come back in as RVUs. So you're going to be doing, I don't know, let's say a couple thousand RVUs worth of work, but your actual report monthly would come back and say you've done 100 or 50 or some ridiculously low number. Like, what are you talking about? I've seen every patient in the hospital. I've done all the rounding. I've done all the consults, and the consults would count because they're pre-op, but everything day of surgery forward after assisting, you're on your own. You're not going to see anything for. So it's really hard to show your value to an organization on an RVU model as an NP in surgery. I can only recommend that you would ask for a salary in basically as the best way to move forward in that. Now, I'm just saying that because I know a lot of people who've been burned. There are plenty of people that have RVUs and do just fine with that, but you don't have the ability to adjust your schedule in the OR. It is what it is. You get consults or you don't get consults. You're doing cases, you're not doing cases. It's not like you can say, well, I can just see people every 15 minutes instead of every half an hour, and I can make more money, because there's no guarantee you're going to see anybody. The surgical evaluation comes as a end consultant. So all that to say, do realize your value, realize that sometimes people will try to squander that and try to bait you into a job and then say, haha, you're going to get all this money. And then just kidding, you're not going to see any of it. And that happened to my wife. She was in orthopedic surgery, and she had a bait and switch from an orthopedic surgeon who said, oh, we'll make all this money in surgery. But then the second that she actually started, he went on vacation like all the time, like a third of the year gone fishing. So she was left doing all these post-op visits in the clinic and never saw anything. And it was very uncool, and it happens more than you think. So just realize that that's something that you need to be thinking about when you walk in the first stop. It's not always going to be a good deal. And if they really push back about you going on a salary, ask why. Internally say, maybe this was a good catch. because if they don't want to pay that, then maybe they weren't intending on paying that. So something to think about. Again, not to get too heavy on you, but I think it's important to think about that upfront. No one's going to tell you that upfront. So that's why I'm telling you now. RNFA versus APRN RNFA billing, very similar with a couple simple exceptions. And if you want a much better, more in-depth talk about this, Gary Hargreaves is able to guide you much more effectively through this because he works for the NIFA billing company and he knows all about medical billing and he can give you a lot more. So check out that webinar. If you haven't already, there's a recording of that on the after hours page on NIFA. Awesome, awesome, awesome information. But that said, from my experience of this is kind of a generalization. So ask him the questions about this, but this is my spin on it. RNFA billing is unique to every state, but here's a couple of simple rules. CMS, which is a Center for Medicare and Medicaid Services, basically all your patients that are Medicare and Medicaid, so the elderly or those who are indigent or those who are below a financial threshold or those with like ESRD or something like that. Those are going to be the main ones you see. The CMS will not reimburse for non-prescriber first assistants. So yeah, like Surg Tech first assistant or RNFAs, they're not going to be able to bill for them. You have to be a PA, an NP, CNS, whatever, just as an APRN, you have to be at least an advanced practice provider or higher, which second physician you can bill for as well, but there's different modifiers if you're a physician versus a non-physician. I'll just say when it boils down to it, this isn't always a reason why they wouldn't take an RNFA in the hospital. They may still say, well, I don't really care if you're an NP or whatever. What I really want is someone who's consistently going to be able to do these cases with me and it's going to help the cases go faster because, well, quite honestly, I can't really bill for you, but I can get more cases done with you than with someone else or inconsistently with different people. So it's still a benefit financially. So there's ways around this, even if you don't have the ability to bill for it. But that said, there are certainly benefits. Obviously, if you would have an NP versus an RN, being able to do this with a CMS population, if it's like a CV surgery population, and you do have the ability to reimburse, my goodness, I would say try to have the NP because you would get more as opposed to less. So it does make a difference. Commercial insurers mostly will cover RNFAs if it's an assistable case. And I say mostly because, again, every insurance is different. They change all the time. This is not a all or none statement. Just you need to know the insurance products that are offered by your hospital as far as being in network. And that's really where it boils down to also knowing what an assistable case is. And on the NIFA course, when you do that, there is a great document that has all the assistable cases that are considered like under 3 columns, like never assistable, sometimes assistable, always assistable. And that basically you can look at the CPT code. You can just kind of do a page search on a PDF and you'll pull up the case of, coronary artery bypass grafting. It'll jump you down to that space. And this is not a NIFA document, but it's a document that I use all the time when I was logging my hours because it was easy to say, hey, is this case something that if I was to bill for this, would I be able to at least get reimbursed for it? And what it really boils down to is it a case that you can justify having a second set of hands there for? And if it is, then certainly you'd say, okay, sure, we'll submit it and see what happens. And most of the time you'll get reimbursed. But that said, every insurance is different. And that's unique to commercial insurance as opposed to like CMS, like the Blue Cross Blue Shield, Anthem, Cignas, those, some are nicer to work with than others. And Gary Hargreaves is the guy to talk to about that. He can tell you all about that. APRNs are able to bill in 50 states for CMS and commercial patients, which is really nice. However, depends on their specialty and certification and hospital credentialing policy. I mentioned this simply to say that everywhere is different. And some places are very friendly for NPs. And example, my wife, again, she was the first nurse practitioner at this hospital system that she was at in a pretty large town, like 350,000 people in the metropolitan area, including all the outskirts. And this hospital was one of 3 hospitals, and they'd never had an NP in the OR before her. So they had no idea how to go through the credentialing process, no idea how to get her actually validated of saying that she's had the skills necessary. And she was fine. She did all the training and was good to go. But it's just everywhere is different. So I would encourage you to look at your credentialing body and say, hey, before I spend the money on going to this NP program or this CNS program or whatever, spend the time asking as a nurse, because they're going to appreciate that. Say, hey, I want to stay in the network. I like working here and I want to go on to school. What's the best what's the best plan for me if I want to go on, so I can be thinking about those things, whether it's like an adult geriatric acute care or an FNP. Everywhere's different. I'm not going to tell you there's one right answer to that, but I will tell you, just talk to the hospital that you want to be at, and maybe do a little bit of a survey outside of the hospital too, in your local area, just to see what you're seeing as far as the people that are in the OR. Are you seeing FNPs? Are you seeing adult geriatric acute cares? Are you seeing PAs? Is this area saturated? Is this area, just crying for more help? Put yourself in a position to be successful. And then one thing you can do, in my recommendation, is go on like Indeed or Monster and look at the different job postings and see what areas of the country they're looking for what qualifications. And that does kind of help get you in the right direction to know what you'll need to be successful. Okay. PAs currently are allowed to bill in all 50 states since they are billing under the surgeon, and the operative assisting is part of the surgical rotation. So that's kind of part of their training. That is a benefit of PAs that is not necessarily for NPs and CNSs, but do realize that that is certainly something that is part of the thumb that PAs are under, that they'll themselves tell you that they wish they weren't under, but that's just part of the AMA's model. So they don't have a lot of pushback because the AMA feels pretty comfortable with their relationship with PAs, because they don't have a full practice authority. There's not a whole lot of that happening right now, where there certainly is. I think right now there's 21 states that have full practice authority for APRNs, and that's a big deal when you're trying to go into the OR and you have physicians pushing back at that. It's all political. So negotiating your RNFA training based on your billing plans. So this is my scenario. You finish NP school, you find your dream job in CV surgery, ortho surgery, spine, whatever. It's whatever you want to do. You're about to interview. What's next? Well, obviously get your ducks in a row, right? But the big thing here is when you are, whatever timeline away from actual graduation, make the relationship really known that you're, one, interested in a position in the healthcare system. I can't tell you how many people I know were in that final semester of school, ready to get out, and then they talk to the medical recruiter or the medical staff office and say, hey, by the way, I'm done with school. And they're like, who are you? I never knew you were a student. Oh, it's too bad. We just filled a last position with somebody outside of the system. We'd much prefer to have you. And what it boils down to is a lot of people just don't get on it fast enough, and they miss the opportunity. And those positions are posted a lot of times cyclically with graduations. So you'll see positions posted around Christmas time, and by maybe January, February, there's a bunch of applicants for those, and people are getting ready, and these jobs aren't going to actually start until the fall, but by the time they're hiring somebody, it can take a couple months, and they know that you're going to be done with boards in May. You're going to be done with school, and then you're going to be doing boards in summer, and then mid-July, August, you're going to actually have all your ducks in a row, and then you'll be able to start maybe somewhere in there to September, sometimes even October. Just depends on how fast your board of nursing is and all that process. So be thinking about this in that process. Be the early bird. Let them know you're looking way before that, because you'll be surprised once you're on the little list of waving your hand saying, I'm interested. You'll have some places that are talking, and they'll say, we knew you were interested. This isn't what we were thinking for you, but is this something you're interested in? This just popped up. It hasn't even posted yet. I don't know how many times I've heard that from people saying, yeah, there was an unposted job that I got because of I knew so-and-so, or they talked, and whatever. It does make a difference. And then the biggest thing, I can't tell you how important it is, plan for your training. Plan for it. Because if you know that the role you want to be in is above your pay grade as far as your training, one, you can spend your own money to go get the training, which is fantastic for them, more likely to get hired. Whereas, quite honestly, not a lot of people are in that position. If you're going through RN to an NP program, for example, you would probably be, working full-time still, or maybe cutting back to part-time. Your income is not as high. You have student loans. You're not making the revenue of a nurse practitioner yet, but you will be. And that's not a great time to be putting a financial investment forward. So one of the smartest things you can do is negotiate that into your starting salary, with the caveat that you'll stay for a couple of years. Say, hey, I get it. There's a vacancy. And anytime there's a vacancy, there's a backstory of saying, why did they leave? And if you can say, look, I know the last two people left within a year. I was here. I was working with the same patients, and I get it. I understand that that's probably a sticking point. You want somebody who's going to be here for a while. I'll give you 3 years in exchange for this, or I'll give you 1 year, whatever it is that you want to negotiate. I guarantee you'll be far more likely to get your hospital to pay for you going through a program like NIFA if you let them know on the front end. And that's what I did. And fortunately, because I had that conversation with them, they hired me and then they planned for it in the next fiscal cycle. And it worked out just fine. And I know people that have since been in that situation, they didn't bring it up in their job interview and they didn't get it paid for because they didn't ask for it. And when you talk about things that you can negotiate for, you can't always negotiate your salary as a new grad and typically assume that you won't be able to. But that said, you can negotiate things that are fringe benefits that aren't going to put you at an unfair advantage of someone else, like training days or, vacation for getting an RNFA training or, things like that. So what ended up happening for me is they paid for the RNFA and they paid for the time that I was going to be away and it didn't come out of my vacation time, which was, I thought, a phenomenal negotiation because I started with a base salary as a new NP. Of course, I'm a new NP. I'm not going to be making a ton of money, but I'm still going to be able to walk in there and say, even if I don't like it here after X amount of years, I can walk away with this training. That's a win. I mean, that's hands down the best thing I could possibly do because they can't take that away from me. So you should worry about this during the interview process, like I mentioned, because if they don't know about it up front, they may say no later. And the big thing then is you're stuck using all of your CME and all of your time to do the training that is what you have to do for a job, as opposed to something that maybe what you want to do. You can't do the stuff you want to do because you're forced to do it all, for whatever money you get. It's typically not enough to cover full RNFA programs because there's too much that goes into an RNFA program to cover that with CME. CME typically is a couple thousand a year, depending on where you're at. As a new grad, it was, I think, $1,500 for me, and then it bumped up to like $2,500 at the first hospital I was working at, and that's pretty common. $2,500 to $3,000, somewhere in that is, I think, pretty standard across the board. Sometimes surgical training will cost you $5,000 to $10,000 to become an RNFA. All said and done, hotels and flights and time away and the actual course. There's just a lot of money that goes into training you. So you have to be thinking about that. It's probably safe to say, put $10,000 away for this training. And that's something you may even say, okay, well, for the first year, you can take out X amount from my salary to get me that training, because you would rather get the training and the value of that doesn't go away and say, take that out of my salary, because then I can always see my salary bump up after that year. And that's pretty common to do too. So again, the hospital doesn't see, let's say, $10,000 as anything more than a drop in the bucket in the grand scheme. But the course is much less than that to go through by itself, and maybe you've already gone through it. If you've already been in the OR, it can be less than that. For a $4,000 or $5,000 investment on your time, if you're by a course, then maybe it's cheaper. But my point being is, be thinking about this when you're negotiating. This is a very common thing to negotiate that they tend to be cool with, because you need this to get the job. You need this to be able to actually bill for what you're doing or to get credentialed in the OR. So these are things that are pretty important to, keep in mind. And yes, CME means continuing medical education. I apologize. CEUs, CMEs, for physicians, it's CMEs. And for NPs, it's usually considered a contact or a CEU. But that said, everyone's a little different in that. Depending on where you go, you'll see different terminology. Training takes time and money is also my point there. It's not just one, it's both. You're going to have to spend time away, and it's a bigger deal. So all that to say, myself as an example, it worked out well for me because I was proactive, and that seems kind of like, ooh, you're going to throw that out there in the initial interview. I waited until it was kind of like already kind of in the, we're interested in offering you a position. And then I threw it back and said, okay, so now we're on the same page that you want me and I want you, we're good, but let's talk about this because this is part of the training I'm going to need to be successful in this role. You want me to be successful in this role, don't you? And they're like, well, yeah, well, sure. Okay. Yeah, no problem. So we'll do this. So I gave them the packet of the info from NIFA, signed me up that day, got me in the system. And then they bumped me back a year and said, sorry, we don't have money for it this year. We'll do it next year. Again, once you got the yes, you can always move forward with it. And that's the biggest thing. So always consider that as a great opportunity to have them pay for it if they're willing to. Okay, this is a couple fun pictures. This is just some of the stuff that we do at Skills on Point. I only throw this in there too because we have a lot of people that go through NIFA and want additional content as far as the procedural stuff that isn't part of the actual first assisting content, but maybe things that you need to know. And let's see, the bottom right there, this is actually at a NIFA course in Vegas. We were teaching some people how to do ultrasound guided central lines, which a lot of times you'll see for like vascular or CV cases, trauma cases, carotids, whatnot. Super fun. the room on the upper right there is actually the room that I'm in right now. I'm in our conference center in Rockford, and I got booted out since there's a meeting in the other area. So I came back here. So it probably looks probably not as clean as that picture. Upper left there, just learned some central lines with ultrasound at our sim center, which is a separate space. And then down the bottom left, this is kind of fun. This is a physician that's actually a surgeon from Costa Rica, if I'm not mistaken. And she came to the US. It's very common to have surgeons that want to be in the OR in the US that haven't gone through USMLE for basically the medical licensure exams. They will work as a first assistant. And she's a CV surgeon where she's from, and she had to work as a first assistant and learn how to do vein harvesting, because everything that she did where she was at was all open harvest, and everything here is endo harvest. So, you know, you never know who you're going to run into, and some very talented people that are just amazing where they're from, and then they come to the US and they have to work in this role. So I'll have to say, you can have some very talented people working in that first assist role that are working well below their licensure. And it's super fun to meet them and hear their stories and do medical stuff with them in their own country. So again, just some more fun pictures of students learning some fun stuff, some chest tubes, thoracentesis, a little small training in the upper right there at our sim center, and the bottom left learning some suture and some basic wound closure. The NIFA program is, I mentioned this because all the people that teach for Skills on Point are NIFA instructors, and we all teach the same curriculum. So there are a lot of people that want to go to NIFA and they want to do that at some point in time, but they're not exactly sure that their skill set is up to par to do that. And we help a lot of people because we use the same nomenclature, the same verbiage. We teach them the same techniques, the same way. So there's a lot of consistency. And that way, when they go on to do NIFA, they're far more successful in feeling comfortable the first day and learning how to do the hand tying and all the things. They take a little time to get under your belt, just kind of a little rocket fuel to propel you. So all to say, you know, some Q&A time, super fun. Love what I do. I'm excited about the fact that I've had the opportunities I had in my career so far in the OR, in education. NIFA has been probably hands down the most confidence boosting thing I've ever done. And I will say that unashamed of all the other fun things that I've done in my life, they were able to get me on a trajectory to be very successful in my career. So I can only say with 100% assurance that if you want to get trained well to be in the OR, NIFA is the program to go to. They really do offer you a lot more hands-on time than any other program out there. And that's really what puts you in a different category than anybody else. You can learn anything you want online, but once you get your hands to it and have people watching you saying, you did that kind of right, but not exactly right, and here's why. It's like, man, how do you know this so well? Their instructors are so good at just watching, and they can just tell from across the room, no, you're doing it wrong. Like, how did you know that? I've watched thousands of people suture. I can tell you're doing it wrong, and this is why. And then, darn it, they're right. They know what they're doing. So they help refine my technique. And every time I go back and help teach the courses with them, I learn more and I refine more. And that's just the whole point of it, is we're all here to get better and help each other get better in the process. The other thing too is if you have any questions to get a hold of me, certainly I'll take any questions you have, but this is my contact info. This is my cell phone. I am more than happy to take any texts or calls. Right now is not a great time for calls. I would say I have the little kids, but I am always texting. So feel free to take that number down. john.russell@aprn.com will get a hold of me. skillsonpoint.com is our website. And if you want any online courses right now, we have a promotion. If you put in the coupon code SWEET, it'll take 30% off of them. So a little something just for you guys for spending some time with me. So is there any questions or anything I can help answer for you?
I was just curious, sir, what's your experience level as an RN before you went to NP school?
I was in the critical care area from 2008 until 2014. So it was about 6 years or so.
Do you feel prepared for your NP program with that experience?
I think it was, honestly. I think everyone's unique. I mean, there's so many different areas you can go. It was kind of a weird thing to go from being an ICU nurse and recovering hearts and a charge nurse and all that kind of stuff, and then go to an FNP program, which was the decision I made based on what was available around me and what was a well-reputed program. My wife went to that program, was like, oh my gosh, this is a great program. You really like this. This person's a great instructor. And she was right, but that was one of the biggest reasons I listened to my wife. Always wise decision to listen to your wife.
Right,
but
right.
That said, but I went to an FNP program, so I was being prepared for the CV surgery part of it, but the FNP program was really training me more for primary care. So I was prepared for the role I took. I wasn't necessarily prepared for primary care, if that makes sense. But
I
think
feel the
the program
exact
did a
same
good
way.
job.
I'm I've been a circulator for 8 years, and and I scrub. I'm wanting to. I'm in NIFA right now. I'm paying for it out of pocket just because I want to have it finished before I even begin NP school. If you don't mind me asking, did you go to a brick and mortar or an online NP school?
I went to a brick and mortar NP school for my FNP. And since then, my DNP was online through that same school. The DNP was offered as an online only program, although it is a brick and mortar school. And then I went to UPenn for my adult general acute care, which I did online since it's a distance-based program. But that said, it is a brick and mortar school, obviously, for UPenn locally, but pretty large online
You
presence.
did an online component. Yeah, I would say that's my only big real apprehension at this point is, there's just so much like, are you going to a good school? Are you going to a bad school?
Mm-hmm.
What kind of reputation?
It's really it's a very important question. And I would say one of the things that the whole pandemic coronavirus-y kind of stuff has changed is the brick and mortar schools that were these great schools, the Harvards, so to speak, right? These are the brick and mortar schools that people go, oh, I went to a brick and mortar school. And some of these brick and mortar schools have very little, if any, online programming, and they were hit the hardest with the coronavirus when you had schools that already knew how to do online education, have better continuity. And I will agree with you, certainly there's a bit of a stigma about online courses and online programs. And I would say that has changed somewhat in the last year here, just because people are having a lot of growing pains at those brick and mortar schools. And I can tell you, I teach at a brick and mortar school, and that's very difficult. They're not sure how to do all that digital stuff. They do a good job of it, but there's certainly more growing pains than programs that have been doing it since the beginning, right? They've been doing it for, decade and no big deal. So I think there is some equalization happening there. Anywhere you go, you're having a hard time getting clinicals. And, it just is what it is. Some places are not as open. People are backlogged. They're waiting from the last year, and it's going to be a while till everybody gets through clinicals.
Right. I'm fortunate. I've got my hospital that I work for is a clinical site for the school that I'm applying to now, and so hopefully that won't. I know that's usually the hurdle everyone runs into. Hopefully that won't be one. I just don't want to. You hate to go somewhere where you didn't actually get enough education to really prepare you for the role that you want to work in. But anyway, I'm sure there's other people who have questions. Thank you very much, sir.
Yeah, my pleasure, sir. Thank you for your question.
Thank you.
Hi, John. How you doing? Hey,
good, man. How are you?
Not too bad. Hey, question for you. So I've been in the OR now for C-sections for 6. How long with 3 different surgeons? How long does it take before you get? Because I've been a nurse for years. I've been a practitioner in women's health for years. It's just how long does it take before you get pretty comfortable? Because it seems completely as foreign can be. And I was also a surgical intensive care nurse, recovered open hearts, but I just, it's as foreign as you can get to me.
Yeah. There's no replacement for reps, right? The more you do of it, the more you get to see how they do it. And there's 3 different people. There's going to be 3 different ways you got to memorize, and they're so similar, but yet so different. And I would say, 50 to 100 cases, you start to see all the weird isms of each person and how they like to do little different things. And, usually that gets you pretty comfy with it, but it takes time. There's no way around it. Once you have enough really crappy cases when things go wrong and you see how that one person reacts and what they wished you would have done, that makes a big difference. And then there's the ones that go really well where you don't really learn as much from because there wasn't as much chaos to deal with. Mm-hmm. Sometimes those are just repetition of a normal x-ray, so to speak. And when you see the abnormal one, it pops up more and you go, oh yeah, I'm used to that. What happened there? That got weird. But it's just ask them. All I can say is just keep on asking them, keep talking. Hey, did you like what I did? Is there anything you'd like me to do differently? How did you feel that one went? Or, ask those questions. If you've got any way of seeing video of what you're doing, that's probably the best thing you can do. The game tape is so important to review if you want to get better at it. And some of that you want to have available, certainly. But if you do have any of that is laparoscopic, or there's anything you can see, if you're just doing C-sections, it's all pretty open. It's just fan steel incisions and multi-layer closure. But certainly there's plenty of things that go wrong that you can learn from. And
Yeah, we've had bleeding, we've had nuchal cords, we've had different things. I mean, I've learned a lot of different stuff, but it's just right now I'm kind of in that macro role where I just see the large picture, all the small stuff. Thank God the tech is really good. I mean, like, they're like awesome beyond.
Yeah, if you've got a really good tech, I would take the time to just get them in a room and ask them all the questions possible. Like, okay, you've been doing this with these guys, what's going on. Guys and girls, there's plenty of, I shouldn't assume, but take the time to say, what's going on here. What the heck do I need to do? Like, what am I doing well? They'll be so honored that you would look at them as a resource, and they want some validation too, because you're another seat at the table that I'm sure they would probably prefer to have their hands at too. So
I got you.
They are great resources. Once you realize that they are your friends, not your enemies, and once they realize that you're a friend and not an enemy, oh my gosh, they can be lifesavers. I would say hook up with them in 50 to 100 cases. You probably be, it'll get better. It always gets better. In the meantime, just don't touch anything sterile.
Yeah. I learned the other day when I went to put on the gown and I kind of moved my arm, and the L&D nurse walked by me, and I hit her with my arm, and of course I had to change my gown. But
they get the look like.
So that was my
sorry. So sorry, I'm human.
Yeah,
my bad.
So, second part of my question is, when of course I have these 6 to write up, and I haven't sat down and write them up. How long should each one of them take to write up on?
For the NIFA? For the
log?
on
the NIFA. Yeah.
It's a great question.
All that stuff.
So when you go through the logs, the biggest thing is to be succinct. Don't write a copy of the OR report. Literally look at those. There's little, prompts and little examples. Just literally list the stuff as it's in there. We can go through and see with a case. On the very far left, you say, I did a C-section, blah, blah, blah. Okay, fine. I'm already thinking a C-section. And when you put all the stuff in there and talk about it, it's pretty straightforward what's going on. I got, 3 pans for this. I got this. I retracted with this. And okay, we did this. When you go through your multi-layer closure, for this layer, we did this stitch with this needle and this type of technique, or, you just kind of go through every single thing very particularly. And then on the very far right side, there's the learning log. That's where you get to, that's your diary, basically. Say, this is my first case doing this. Oh my gosh, what am I doing? I think I accidentally sewed this to that. And oh my gosh, you can be as in detail as you want there. That's for you to reflect on just as much as it is for us to grade. We want to make sure that you're getting something out of each case, and certainly you will. But if you say, it's the same, it's a boring one, well, why should it count for anything if it didn't really teach you anything, right? You got to learn something from it.
Gotcha.
But that said, these are all pretty straightforward. If it's the same case, they're all going to look pretty similar for that middle point, except for anything that's unique about it.
Okay. And then the next, one last question, because I'm sure there's other people that need to get on here. But when the pre-op and post-op, I clear people for surgery.
Yep.
So I will do their EKG. I order their labs. Can I use those as my pre-ops?
Yep, absolutely.
And then the post-op. So